Okay, so Greg, we are ready. I mean, I do not know, I'm hoping that we are streaming because you say ready when we are. So hopefully we have started. And first of all, thanks everybody for making it today. This is the last event in a very dense week with a lot of events. And we wanted, as I mentioned to our panelists, to keep this as light as possible because it's the last event of the day, and also because there are people from Australia where it's midnight and there are people from Canada where it's very late in the morning. But then the people that were proposed to join this panel were quite wonderful, and we thought we allow some time for everyone. I will also take 1 minute to say how we came to the decision to make this panel this plenary a women's event, women's health event. This comes after a long discussion on various fora, and thanks also to Arpana and to Greg for prioritizing this at Manchester and for the festival, because we've been seeing various levels of progress or not across the world towards SDG 5. We have also been seeing, though, particularly with COVID-19, a backtracking along different modalities and in different sectors on women's rights, on women's access, on women's health, not only for health, but also in terms of economic empowerment, and also, sadly, not only in developing countries, but very much in developed countries too. We have seen, I think all of us, an inordinate amount of burden landing on women over the past few months and across generations, because they have to care for the elderly and they have to care for the children. And many of them have been in kind of agreements, employment agreements, where there were softer agreements or looser agreements, and those have collapsed, so they have lost means to live, and they have potentially even lost access to healthcare services where those are available. So I will pass the ball to Liz, and I hope you will all be able to stay with us for as long as possible, so then we get a chance to have a little bit of dialogue. So Liz.
Thanks, Elena. Hi, everybody. Yeah, as Elena said, it's a real pleasure for us all to be here today. And we want to welcome you. Good evening, good afternoon, good morning, whatever it is for you. I'd just like to take a brief moment as well, if that's okay, to thank Elena, and also a special thank you to Professor Arpana Verma for bringing so many inspirational women together here today, and also just for being an amazing woman and an amazing leader to us all here at Manchester. She's incredibly kind, and her dedication and tireless work ethic is a true inspiration to us all. So thank you, Arpana. So without further ado, I'd like to now introduce Professor Cathy Bourne, who is Director of the WHO Collaborating Centre for Women's Health at the University of Melbourne, and she'll be discussing the global picture in relation to violence against women and girls and the Sustainable Development Goal number 5. Over to you, Cathy.
Thank you so much, Liz. And thank you also for the promotion. It's associate professor, but that's okay. It's lovely to be here. And thank you so much to the University of Manchester for inviting me, and for all of the hard work that's gone into what looks like an incredible week. I wasn't able to catch a lot of it because of the time difference, but I'm very glad to be here for this exciting panel. I've been asked to speak about violence against women, and that is the focus of my research here in Australia. I work in both Australia, but also in Asia and the Pacific, in low and middle income countries in our region. And so it's that experience that I'll be drawing on in speaking today. Gender-based violence, and specifically violence against women and girls, has been a long-standing pandemic. So we talk about the global pandemic in relation to COVID-19, but this is a long-standing issue that women and girls have been facing around the globe. Just under a third of all women have experienced physical or sexual violence from a partner, or from a sexual violence from a non-partner. But most commonly, women experience violence from their current or ex-partners, and about a quarter of adult women have this experience at some point in their life, and many women are living with this experience at the moment. And so I realise that will include women who are listening today, and so my deepest empathy for your experience, and I hope that the way I'm speaking about violence today is respectful of what you're going through. In Australia, where I am, the proportion of women who've experienced violence at some point in their life is very similar to that in Europe, actually. Around between 1 in 4 and 1 in 5 women will have this experience at some point. However, my work in Asia and the Pacific, and particularly in the Pacific, is in countries that have the highest prevalence of intimate partner violence in the world. In some countries, more than half of women will experience intimate partner violence at some point in their lives. And in many countries, 20 to 30% of women live with violence at any one time. So there is a really big variation in prevalence of violence across the world. And I guess the good thing about that is that it confirms that violence is not inevitable, and it's also that confirms that change is possible. And we do see variation over time. And I think that's something I want to hold on to as a source of hope. However, unfortunately, over the last 18 months, we've seen the incidence of violence change quickly, but unfortunately, that's been in the wrong direction. In April last year, around half of the world's population was being asked to stay home, with I think it was over 90 countries having some form of lockdown at that time. So we were all being asked to stay home to keep the community safe. But as you will have realised from my opening remarks, the home is not a safe place for very many women and children. And globally, there's increasing evidence of the clear relationship between responses to COVID-19 and consequences of the pandemic and increased violence against women. And this was seen very early on. In February 2020, police in Hubei province in China reported that they were seeing a tripling of domestic violence cases compared to the February of the year before. Police departments, health services, women's refuges, and unfortunately coroners' courts across highly diverse countries have reported the ways that the pandemic have undermined women's safety in their homes. In some instances, patterns of violence have also changed. So, for example, initially in the pandemic, women's services in Australia were reporting an increase in requests for assistance from older women who were subject to violence from adult children who'd moved back home with them when their jobs disappeared. Some services also initially reported a drop in help seeking during, particularly early in lockdowns, when women could no longer make phone calls because they were always being surveilled. These same services often then saw an explosion in online chat requests for assistance because women could do that sometimes even when their partners were in the same room. However, it's often when lockdowns have been lifted or eased that there's a huge demand on services as women can finally seek help from the homes where they've been living to keep us all safe, however, not safe for themselves and their children. And this is a phenomenon that's seen across countries, in high-income countries, but also in low and middle-income countries. And we know that in many settings, the impact of COVID-19 has affected women's access to cash, their access to food. It's had an impact on mental health and on their exposure to violence, and really undermined their ability to leave a violent partner or a violent household. Women and children experiencing violence now need immediate support in the context of COVID-19, but there's also a need to really generate robust data about the impact of the pandemic and the ways that we're responding to it to ensure that we learn about how to protect public health whilst protecting women and children's safety at the same time. And learning depends on good data, which brings me to discussion of the Sustainable Development Goals as asked, and how we measure whether we're achieving them. So under Sustainable Development Goal 5, which is achieve gender equality and empower all women and girls, sits target 5.2, which is to end all violence against and exploitation of women and girls. So there are two indicators for target 5.2. The first one is 5.2.1, is the proportion of ever partnered women and girls aged 15 years or older who've been subject to physical, sexual or psychological violence by a current or former intimate partner in the past year. And indicator 5.2.2 is the proportion of women who's experienced sexual violence by someone other than a partner, so non-partner sexual violence in the last year. There is a need for population-based prevalence data, and the number of countries around the world with survey data is steadily growing. But doing this kind of research is really different than other kinds of prevalence research that people might be used to doing on, say, population prevalence of diabetes or the prevalence of people who smoke. And there's an urgent need to build capacity around the world to ensure that prevalence research in particular on violence against women is both rigorous and safe and ethical. And studies around violence against women take a whole lot more planning and training and capacity building and systems around them to ensure that this kind of research is done safely. So since 2016, UNFPA, supported by the Australian Department of Foreign Affairs and Trade, has led the NOVOR Data Initiative to strengthen the capacity of countries across Asia and the Pacific to measure violence against women. And as part of this initiative, the University of Melbourne and Australia's National Research Organisation for Women's Safety have developed the NOVOR Data course, which we initially focused and delivered in Asia and in the Pacific. But because of, with the impact of COVID, we can no longer travel and participants can no longer travel to come and do the course. So it's now being delivered online, which has allowed us to expand to have a global focus. And we currently have participants from 27 countries from all inhabited continents undertaking the course at the moment. And that program really is around building people's skills and knowledge and depth of understanding about the relationship between gender and gender inequality and violence against women, how to do safe and ethical research on violence against women, the specific skills that you need to do good prevalence research, and then also turning that research into action and what you can do about it to bring about change in a country. And it is important that we build skills to measure these different forms of intimate partner violence and non-partner sexual violence, because it enables countries to sort of comparably report against SDG indicators, and these are really common forms of violence. But it's sort of misleading when we say that these data, say the prevalence of violence, intimate partner violence in Australia in the last 12 months, say, might have been 3% or 5%. And if we say, well, that's the prevalence of violence against women in Australia, that's misleading. The indicators don't capture the whole picture of violence. We know particular groups of women are often underrepresented in national prevalence studies for a range of reasons, and that would include women with disabilities, migrant and refugee women, women in institutional settings such as prisons or in residential care, Indigenous women, women living in remote communities, for example. And countries often only collect information about the experience of women in particular age groups, and this means the experiences of older women in particular are overlooked. The indicators also do not capture specific forms of violence, including structural violence. This could be experiences of women with disabilities who might experience violence that's both gendered and related to their disability. So that could be, for example, destruction of mobility assistive devices, or it could be about the experience of migrant women who experience violence related to their visa status, so destruction of their passports or residency documents, or threats of deportation, or threats that their children will be taken to another country. And the indicators don't capture the way that perpetrators of violence around the world use institutions such as the law and justice system and the courts to further inflict violence on women by filing for counter-intervention orders or vexatious litigation, and by dragging women and children through protracted and repeated appeals in family and other courts. And in particular, I want to mention here the thoroughly discredited diagnosis, very much in inverted commas, of parental alienation that's commonly wielded against women who are trying to protect their children from an unsafe parent. And I believe there was a BBC program about this screened in the UK this week. So I realise I'm at time and I don't want to take anyone else's time, but I do want to highlight that violence against women is an incredibly common experience, and it's a public health priority. It's often seen as a law and justice issue or as a social issue, or sometimes misleadingly as a cultural issue when talking about others. But of course, it's common in all cultures around the world, and it's a huge public health priority because of the impact on women's mental health, physical health, and that of their children. So I will conclude there, and I'm very grateful that the organisers included a focus on violence in a session on public health and women in global health. Thank you.
Liz?
Thank you so much, Cathy. That was absolutely wonderful. I was just going to try and field some questions for you, but I'm having some issues with accessing the questions at the moment. I do apologise about that.
Shall I copy them in the chat for you?
Oh, please, thank you.
Yes,
If you,
and I can see one there, so I could start answering that one if you like.
Oh, thank you so much.
That's all right, Liz.
Also, if you refresh the document that we have, you should be able to see all the questions that we have there for Margo and everybody else.
Thank you. There's one question I can see there about how can we continue to build people's confidence to report domestic violence and abuse. And I think that largely that's also about building the capacity of the people that they report to. So women don't disclose, usually for very good reasons, because they don't feel safe to do so. So the women I've worked with in Australia, for example, would describe so many missed opportunities to report or to be supported into specialist services in health settings, for example. And that's because health workers hadn't been trained at all in recognising violence against women or how to appropriately respond. And women will sense that. So they may be trying to seek help, but if they're not getting a sort of empathetic response from health workers, then they won't disclose to them. And that would similarly go for any other service system that women might encounter. So I think women will have more confidence to report when they feel confidence in the systems that they're reporting to. And that is largely about building the capacity of those systems. So women are not seeing in the media instances of other women reporting and having their confidentiality breached or being disbelieved by police or health workers or whomever it might be. So I actually think it's sometimes less about the women and more about who they're disclosing to or reporting to. And certainly as a researcher, if you're doing a prevalence study, you're wanting women to actually accurately report, you've got to have highly trained enumerators doing that prevalence survey. Thank you.
I think we also have one more question. Well, I don't know. I have a question, but Liz, you want to take anything else from the floor or anything else from your own?
Hi, yeah, thanks so much, Cathy. Excuse me. I just wanted to ask what your views were on how we can make stronger collaborations between different fields, for example, the legal sector in terms of empowering women and their rights, and also what sort of steps might we take in tackling, you mentioned about alienation in the courts, and I wanted to ask you if we could talk a bit about sort of rogue experts and how they may be employed in certain industries. If you could comment on that for us, please.
Yeah, so to your first point about, well, they're actually linked, I think, but to the first point about stronger collaboration, say between women's services and the courts and police, or it could be between the health sector and women's services, or I work a lot with migrant and refugee settlement services. It is largely about building relationships of trust between these groups who often don't have a history of working together, or who, when they've tried to work together for various reasons, there's been situations occur that break down trust. And so it's bringing people together, I think, a lot of the time in forums where they've got an opportunity to share their different perspectives about a woman's needs or experiences, and how they can best support her. There's definitely a need for training and ongoing training, not a one-off, domestic violence awareness training is of very limited value. It needs to be ingrained and sustained. But I also think that certainly in the judiciary and the courts and the law and justice system, there's just a gross underrepresentation of women in the judiciary and amongst lawmakers. And so I think that moves towards gender equality in people who make the laws, who implement the laws, who make decisions in courts will go some way to recognising and believing women, because a lot of, I think what you're referring to, Liz, is about women who are reporting domestic abuse not being believed by a range of services. So I think it's going to be a multi-pronged attack, and none of this can be done without funding. And so the state of Australia that I live in Victoria, saw a very large injection of funding come about. And there's a whole range of reasons and decades of advocacy brought you know, built up to this point. But it was really a very high profile death of a child, and his mother, being such an incredibly compelling advocate, that almost immediately had a Royal Commission called into family violence. And so I think that services getting in and behind and supporting survivors, women who've got this lived experience, to advocate for their needs, and to support them to, you know, articulate their concerns to people like the courts, the police and so on, is a really key part of working with survivors, is such a key part of bringing about change.
Thank you so much. Do we have time just for one more quick question, Elena? Just very quick.
Go for it, because it's an interesting topic. Also, we have 4 different messages in the chat, and
yes,
maybe there's an expanded version in confidence, which I think builds to others. So go for it.
Yes, that's what I was going to read out. So, one of the questions we've had, Cathy, is well, 2 of the questions are around stigma, so I'll just combine them. One of our members says, in some countries, the culture is so toxic that women are far from valued. People who are feminists are mocked and called feminazis. How do we change this culture?
That's a big question. So I had a fantastic PhD supervisor who was South African, who always would quote Desmond Tutu that you know, how do you bring about big change, or how do you eat an elephant? It's one bite at a time. So I think definitely it has to be a sustained effort, and to know that women, to know that they're not alone. This is such a common experience. There are there'll be people in your family who've had this experience, people in your street, people in your workplace. So women working together to support each other. And I think with the work we do with survivors here, and we do a lot of work as researchers with a group of women who've had lived experience of violence, to advocate for their own needs, is to work with them together as a group so that they can support each other to then speak out publicly. And that is particularly difficult in some settings, in, say, Papua New Guinea or Solomon Islands, some of the countries that I've spent a lot of time in. The backlash is really difficult. So it's about planning ahead for managing backlash and resistance, and investing resources in addressing it. And that involves anticipating some of these false experts that do turn up in courts and in other settings, with things like this really thoroughly discredited idea of parental alienation syndrome, and having counter experts who really can draw on genuine evidence to ensure that women are listened to and believed.
Thank you, Cathy. Thanks so much. I think Elena's going to introduce our next speaker now. Thank you.
Just 1 second. Thanks a lot. Just to say that there are some questions that we didn't manage to answer, but we are saving them all in a document, and we hope to be able to report and make something more cohesive in the report of this, because it's a very diverse group. So any question you put in the Q&A, and thanks again to Greg and Arpana for writing that, we are actually transferring over to doc. So if you don't hear an answer there, expect to see an answer in a few days when we release sort of blog report for this one. So our next speaker is Dame Professor Lavender, who is a director of a collaborating center for childbirth and for women's and newborns health at the Liverpool School of Tropical Medicine. And I think a topic which has been very close to our hearts for many, at least for many of us, has been neonatal and perinatal health. And of course, obstetric outcomes, particularly in LMICs, but also in many European settings, rural, remote, those having access, for those not having access. So, Professor Lavender, thank you for taking the floor.
Thank you. I have actually got a presentation, so I'll just share this.
Yeah. We can see it. Perhaps you go in slideshow mode.
Yep.
Thank you.
Okay. That's great. Thank you, and thank you for inviting me to contribute to this really important seminar. I'm going to actually use my own research experiences from sub-Saharan Africa as an exemplar of the challenges faced by women, particularly related to obstetric fistula and stillbirth. And by doing so, I hope that it demonstrates the challenges of achieving SDG 5 within this current context. So I'm going to talk a little bit about an NIHR research group which I lead, which is across 6 different countries in sub-Saharan Africa. These are my partners, which are in Kenya, Uganda, Tanzania, Malawi, Zimbabwe and Zambia. So if we look first at stillbirth, we all know that it's a global tragedy and that 2 million babies are stillborn every year. 75% are from sub-Saharan Africa and South Asia. Most stillbirths are preventable with access to high quality care, which really means that we should be doing something about this. And it's amongst one of the most traumatic life events for parents, for women and also for their partners as well. It's highly stigmatised in many settings, and it's estimated that 4.2 million women live with depression as a direct consequence of having a stillborn baby. And it's also associated with many comorbidities, which are often overlooked. So we embarked on a research programme, and time doesn't allow me to go through all of this. But basically what we've done is we started off doing some exploratory work, which then moved on to some mixed method studies, and then some intervention development and testing throughout the last 4 years. And we looked at the prevention and detection of stillbirth, the promotion of evidence-based intrapartum care, and also ensuring humane and respectful care for bereaved parents. And this slide probably tests your knowledge of flags a little bit here, because these are the countries that were involved. Then if we look at the experience of stillbirth and fistula sufferers, often 1 out of 5 women with a fistula also has a stillborn baby. And the stillbirth risk is 99 times greater when women develop an obstetric fistula. So you can just imagine that a woman gives birth to a dead baby, and then she's also physically traumatised by the obstetric fistula as well. So these are the most vulnerable of women in society. These women are incontinent of urine and sometimes of faeces as well. And some women suffer with this condition for 30, 40 years. Some never go treated, despite the fact that the surgery is relatively simple and costs around $300 to conduct. And the World Health Organization estimates that between 50,000 and 100,000 new cases each year. So we did some work as part of our programme. We did some qualitative work exploring experience of fistula and stillbirth from different perspectives, from the women, the partners, community workers, key stakeholders and health providers. And like the last speaker alluded to, stigma was very much still prevalent. Women were called a mongoose if they had an obstetric fistula. A mongoose is an animal that is foul smelling and also isolates themselves. And if you have a stillborn baby in Sub-Saharan Africa, in certain countries, that childlessness makes you worthless within society. We also found a lot of cultural beliefs that were impacting on the women. Women were accused of having HIV if they had a fistula, being a prostitute or a witch, and similarly with the stillbirth, being an adulterer or being associated with evil spirits. Women were isolated from the church and social gatherings and community events, and in both cases psychological morbidity was prevalent. So we can see that if you have both of these conditions, really you are the most vulnerable of people within that community. We identified a number of problems which we're actually working on now in developing an intervention with local communities. But you can see from the left-hand column the problems identified, where the beliefs, evil spirits and witchcraft. And you can see here some of the participant voices on the right-hand side, which provide exemplars of that. Stillbirth and obstetric fistula was also seen as a punishment for wrong behaviours. And this second quote is basically talking about these conditions and the stillborn baby being a case of, because the boyfriend's family was disgruntled because of an argument, that then they were being punished for this. They had lost him, we too had to lose someone, like revenge. Also, the culture ignoring a woman's feelings after perinatal loss was very prevalent across all the countries. The woman doesn't have much say in what happens to the baby. For example, she doesn't contribute to the burial. She doesn't have a say on whether she sees the baby or not, whether she holds the baby. And this community worker was saying nobody cares about her or her inner feelings. And the women generally had limited decision-making capacity. And you can see this from the last quote. And it says that in such instances, many mothers suffer stillbirth, remain silent with their pain because the husband is the one that makes the decisions. There's also a lot of despise from family, friends and people. You can see from this top quote here, this person was saying that they had nobody to go to for help because everybody despised them. There's rejection from the in-laws, and you can see from the second quote, my mother-in-law at the time was convinced that I was possessed because according to her, I had sacrificed my child so the evil spirits visit their family. There's also a lot of marriage breakdown throughout our programme, where husbands would abandon the woman because of a fistula and or because of a stillborn baby. And this woman was saying that he actually placed me in public transport vehicle and handed me over to a neighbour. But there's also the impact on the family as well. And some friends withdrew because they were the sister to a careless woman. So this was a family member explaining that it had an impact on her too. It changes the social status of anyone who suffers from it and their families. And there was a huge amount of discrimination that was evident. And I think that this representative from FIGO a couple of years ago, this quote actually sums things up. And this is related to, only one woman in 50 having access to fistula treatment. And she says that we see these staggering inequalities in access and quality of care across so many critical areas of women's health, from sexual health and reproductive rights to cervical cancer screening and treatment. I think that these examples just show that women in LMICs face significant barriers accessing quality healthcare. And this is as a result of economic, discriminatory and cultural practices. And I haven't had time to show you all of these today from our research. Women bear the global burden of perinatal morbidity and mortality, but they have the reduced decision-making power to do anything about it. Women who are poor, least educated and residing in rural areas have lower access to care, worse outcomes than the more advantaged women. And we found lots of evidence of discrimination in our work. And our NHR research group tried to address women's rights to healthcare equality using a whole systems approach. And we have reported on several aspects of this if people want more information. I think that trying to empower women in such a taboo area has been a challenge. The way we've tried to do it is by using community engagement and involvement groups, and they have been instrumental in moving things forward and having impact in these areas. We've used a lot of participatory research approaches to enable that we've had all the key people involved, and stakeholder involvement again has been key to this. We've used the media and we've also developed various networks so we can keep the conversation going. And I just want to end on a couple of quotes, and this one from Meghan Markle, where she says you'll often hear people saying you're helping them find their voices. And she says, I fundamentally disagree with that. Women don't need to find their voice. They need to feel empowered to use it, and people need to be encouraged to listen. And I often ask who is actually listening. And finally, this quote from Michelle Obama, who said, "The measure of any society is how it treats its women and girls." And I just wonder how we're treating these women who have had both a stillborn baby and experienced a fistula. Thank you very much.
Thank you very, very much for this, I think, I would say moving presentation, because it's a topic for which we have very little knowledge, I think, globally, and it's a neglected topic in terms also of the agenda and the discussions for empowering women or providing access. I have a couple of questions. First of all, let's see if there are questions. I don't think there's something from the audience. Yeah. So for me, the problem is well described. There are guidelines going back to 2006, clinical guidelines for access and so on. Why is it keeps rising? Why not much has changed? And more to the point, what do you think is the most relevant intervention going at grassroots level to eliminate stigma, investing so that there is access to the care provision rather than anything else, and or building, increasing literacy across communities, because there are different modalities. And also your qualitative analysis was very interesting, but I'm afraid for many rural European areas, the stigma for childbirth and fistula and many other similar things, including incontinence, post C-section and so on, is not that far off this descriptive or the descriptors we've seen. So thank you.
Yeah, no, I agree, and there's kind of lots of answers to the question that you asked. I did actually have a slide which I removed in the interest of time, which actually showed the amount of research that's been carried out on stillbirth, and it quite clearly showed in the Lancet series on stillbirth that the most active research has not been in the places where they've had the highest limits. So most of the research has been conducted in high-income countries, whereas 99% of stillbirth is in low-income countries. So that is one way that we're trying to tackle it, by raising the issue through the research and evidence-based practice. I think community engagement is just pivotal to making changes. And just to give you one example within our programme, that we have community engagement groups in all the different countries, and in Zambia we brought the community engagement involvement group to the Ministry of Health and let them present their experiences, and that has had a real knock-on effect. And now the Zambian government have actually acted, and they've done a national audit on stillbirth, and they've implemented various guidelines and practices as a direct consequence of that. So that has been really, really important, I think, for moving things on. I think the other thing is just by talking about stillbirth and talking about fistula, because both of those things in the areas we were working were taboo areas, and you weren't enabled to open that conversation. And even in my first stakeholder meeting in Kenya, we sat round a table and I gave a presentation about the research we wanted to do, and there was total silence, and these were mainly health providers and ministry workers, etc. And then one of the health providers put a hand up and said, "We don't talk about stillbirth." So that was our starting point, whereas now the conversation is going. So as the previous speaker said, we eat the elephant one bite at a time, and I think that's what we're trying to do.
So thank you very much. A couple more. There is, I think, a Q&A. Oh, Cutting for Stone by Abraham Verghese is an excellent novel, but which one part describes OF and its impact on the life of women in such a poignant way that has always stayed with me? Very recommended. Okay, it's a recommendation, but thank you. Okay, going back to research. Another thing on the stigma, and so we do have refugee camps in Europe, and also we have had very poor areas and even ghetto areas in the European region and broader. And we've seen similar taboo issues on stillbirth. I don't think I've seen data on fistulas, but I've definitely seen data on stigma for women with incontinence or women after stillbirth and so on. And I've also seen problematic, let us say, birth because it's a result of forced conditions or rape even, or because of trafficking. And then the families are not there at all in terms of social support. So what about, I mean, the focus here is mostly friends and family letting loose in terms of networks. So do you think there could be, in terms of building networks, there could be a role in terms of supporting women beyond their communities or outside their communities, but to build networks by using mobile phones or by using social media or by using, because this for us to say in Europe is easy, but for LMICs or for this condition is not.
Yeah, no, you're absolutely right. And one of the things that we've done is set up WhatsApp groups, and the women have really liked that, to know that there are other people who have got similar issues they're able to talk to. So that's been one thing that we've done. We're also trialing a device as well, like an iPad device, which will help people get information and know when they need to refer. And we've done a number of different interventions related to community videos, where we've had women and their partners speak to the community, to say, look, what you think about this is not actually right. Let's stand together and make things better. We've also developed a board game related to compassionate care as another way that, for people to learn about, being respectful to women. So very much multi-component interventions, trying to address lots of different domains of the challenges that the women are facing.
Liz, do you have any questions for Professor Lavender? Or
Hi. Oh, sorry.
Not at all. Sorry, we're having also connectivity issues and document reference issues. Yes, please, Liz, go on.
Yeah, hi, thank you so much. I just wanted to ask if you'd be able to comment more broadly on obstetric violence, and in particular in the UK. We're seeing that a lot of women are not aware of their right to choose, for example, in terms of the type of birth that they have. And there's been some really interesting projects such as the Positive Birth Movement set up. And I just wondered if you could say a bit more to us about those sorts of movements and obstetric violence more broadly.
Yeah, I mean, I think that, across the board, wherever you are in the world, childbirth doesn't seem to be high on agendas. But thankfully, there are a number of movements in the UK which, are promoting positive birth and trying to, to put in processes and strategies to enable women to make that choice. I mean, my main focus is kind of not on the UK, but I do believe that things will move in a positive direction. I think there are a lot of UK researchers who are doing work in this area.
Thank you so much.
I think we had a raised hand from Yonette, which we didn't see, but Greg did. Yonette, would you like to? We haven't introduced you yet, but perhaps you would like to comment.
Well, yes, Tina, thank you for that presentation. I think as researchers and as scientists in this area, we tend to focus on delivering the research and documenting the evidence and the outcomes. And one of the things you included in your work, community engagement, that's become so critical, because that's where we really and truly translate. So we're not talking at them, we're talking with them, we're engaging them. And I noticed you had some men in the group, which is a critical piece, because as we work on women's issues, engaging men, the more they understand, not that we're leaving the women out, but getting a broader understanding is critical. So I just wanted to accentuate that and commend you on the community engagement aspect.
Thank you for that. I mean, we didn't have men in all the community groups, but we did in some, and we left it very much to the facilitators in country to decide what was appropriate or not. So for example, in Kenya, they had a mixed group of men and women, whereas in Uganda, they wanted a group of women and a group of men. But I absolutely agree. So, we're not going to move forward unless we have that active engagement. So thanks for highlighting that.
This is also very interesting, very, very briefly for us, because when we were doing refugee and migrant capacity building, and we were doing the perinatal health modules with midwives and peer supporters, we got a lot of flack because half of the European countries, half of the experts wanted women from local communities in the countries that they were receiving these people, and the other half wanted from their population, and we said they should be from their communities because of what we were seeing. But I think for the way we are structuring interventions, there's perhaps something maybe Cathy and Kronaki will discuss more about co-creating. So have you had an opportunity to work with these women to set up more research? And I know we're over time, Liz, but just this one. Have you had a chance to involve them in how you structure the research and the topics?
They were in it right from the very beginning. They decided on the research. They contributed to the design. They laughed at our questionnaires and made us change them around. They interpreted our findings with us, and they co-authored the papers. So right from word go till the end. And they are now helping us to make the best impact of those findings. So we would have been absolutely lost without them.
Thank you. Tiny point from the audience is whether the research that was being conducted in Zambia is still ongoing.
The research in Zambia has been published, but we are doing further work in Zambia. We've just got some further funding to take some of this forward, so we are going to be continuing in Zambia and the other 5 countries.
Okay, thank you for answering that, and I'm passing to Liz to introduce our next speaker.
Thanks, Elena. Thank you so much for that. Our next speaker is Catherine Bowman, and she is a Canadian researcher and healthcare advocate and Vice President of the Alberta Lymphedema Association. And just to give you a bit of background, in 2007, Catherine's mother was diagnosed with cancer-related lymphedema. And at 14, she set out to create the first pharmacological treatment for her mother's incurable disease, and has since led a national research effort exploring lymphedema from a pharmacological and psychosocial and surgical perspective. She was named one of Calgary's top 40 under 40 by Avenue magazine and Forbes magazine's 30 under 30. And she's doing some absolutely amazing work. So over to you, Catherine. Thank you for joining us today.
Thank you so much, Liz, for the introduction, and again to the committee for inviting me to take part in today's event. I don't have a formal kind of talk for the topic, because we did connect just yesterday for this, but I know Elena graciously we worked away into kind of having a question and answer along the way. Just before we do that, I did also want to just take the opportunity, coming from Calgary, to acknowledge the traditional territories of the people of Treaty 7 in Southern Alberta, and acknowledge that the city of Calgary is also home to Métis Nation of Alberta Region 3. So just wanted to share that information before we get going.
And thanks for joining us. And it's an intense period. We've been there with exams and everything else, and also the time difference. So very briefly, it's very good to see young people, carers or patients, or just inspired people starting early on to be involved in either entrepreneurial activity or research activity and so on. And you were in such case. So would you like to tell us what motivated you in your own, of course, words, and where do you find yourself? I think it's almost a decade later, yes?
Exactly. Yeah. So as briefly kind of mentioned in my bio, my work began when I was quite young. My mother was diagnosed with stage 3 metastatic melanoma, which unfortunately had spread to her lymph nodes in her legs. And for her treatment, she afterwards developed secondary lymphedema. At the time, I was about 8 years old, and I watched my mother's life change with this lymphedema diagnosis. We quickly recognized that this is a disease affecting many men and women, but disproportionately affecting more women. That was not well recognized. There was not much research in the area at that time, and we're still working towards bringing more research into the field. But I saw both the physical aspects of lymphedema manifesting it's themselves in my mother's life, but then these kind of psychosocial changes, which I will speak about, I'm sure, during our conversation, Elena. And so things like, listening to my mother playing piano, she wasn't able to sit on her lymphadematous limb for long enough to practice piano. And so that was something, that might seem small where, she can't play piano, but in the household, there was less music. Or myself and my 3 brothers, we began to need to support the family by cooking different meals or driving each other to different places because my mom had to take care of her therapy. Resting her leg at different periods with the lymphedema and the physical therapy meant that she was spending hours alone in her bedroom and unable to work. So at that time, I wanted to make a difference. Of course, I wanted to care for my mother. And so I promised Mom when I was 8 years old, I would develop the first pharmacological treatment for the disease, which everyone said that's very tender and very kind of you. But that was a promise I intended to keep. So at the age of 14, I ended up beginning to develop a research proposal around the idea of 3 particular compounds to try to treat this at the time and currently incurable lymphatic disease. And connected with researchers across my home province of Ontario and began to form different collaborations with teams, moving then to Calgary to one of the only lymphatic and lymphedema labs in all of Canada. And from there, basically building teams of researchers, clinicians to really look at lymphedema from multiple angles, not just the drug treatment where it began, but now from the psychosocial standpoint, the healthcare delivery standpoint, and the surgical piece as well. So that is kind of how I got involved.
Let me ask a few things, because this is not, you being very young, this is not far back, and Canada is a very well-developed country with a very good system. So your mother, of course, was a woman and a mother and had a family to take care of. And the question which to me comes to mind is, you wanted a pharmacological treatment, but were there other things that were missing? So was there additional support provided for you, not to do your research, we'll come to that in a second, but as a family and for the children and of course for her? And I'm talking social support and potentially physical modalities. So was there anything there with Canada being so developed?
That's a wonderful, wonderful question. So we were one of what I would say the lucky ones who had an oncologist who recognized the lymphedema when it presented. So we did have our direct support and a specialist to say, okay, this is lymphedema, but I can confidently say that is not the typical case for many patients who either are misdiagnosed and receive a late diagnosis, and then their lymphedema becomes progressed, or they don't receive a diagnosis at all, and they are silenced with their lymphedema, not knowing that there is some support, though it is not by any means what I feel adequate at this point. So from a familial standpoint and from a treatment standpoint, there's a lot of physical therapy that's involved with lymphedema. And not all of this is covered by our kind of provincial healthcare systems. It really does depend on different provinces. And so Ontario has one set up. In Alberta here, we have been able to advocate and get some degree of clinical support. But for my mom, there were many things that were coming out of pocket for her treatments back then and even now. And so as a family, we were in a single income household because she was unable to work and then had these additional costs. Things like I spoke about, just these changes within the family, being an 8-year-old and learning all the nuances of trying to cook and trying to clean and collaborating with my brothers. We became very close in that, though it was a very difficult period of time. There are few, but they do exist, kind of patient groups and support groups within the community of lymphedema. But this is hard to access when you don't even know you have the condition a lot of times, again, coming back to that misdiagnosis and identification challenge. So it really is a multifaceted kind of challenge with the lymphedema, this financial component, this lack of community, and the lack of recognition that we are seeing.
did you find, little or few as the networks may have been, or the people, did you find other peers your age, perhaps even at the time, that had similar aspirations, and or did you couple with them or pair with them or collaborate with them? And also, you did mention you collaborated early on. 14 is very early to start collaborating for research. Even if your parent, even if not in your case, but even if your parent is in a clinical trial and so on, it's an early stage. So did you find apprehension? Did you think that the system facilitated that, or were there people, specific people? Sometimes we come across inspirational leaders and inspirational people, or one single person which facilitates. So what was the catalyst to facilitate this for you?
For sure. So I think from the first standpoint, if I had found kind of peers, say whose parents were affected specifically by lymphedema, that was not something that I had ever found actually. And to this day, I just kind of meet people at random who are like, yes, my parents also had this, but I've never really had someone to talk to about it. So as a young person, it was me and my brothers who had that shared experience, and they were kind of my support community as a young person. The way in which I found myself into actually the research and the protocols and all these wonderful mentors that I had in the research community was actually through a science fair. And so I was a science fair kid and thought, wow, I could see all of my science fair colleagues doing wonderful things with biomedical research and healthcare advocacy and research. And I thought maybe I could use this as a platform to make my way through this particular endeavor. And so I reached out to a PhD candidate I knew through the science fair actually, and she helped me start to piece together the knowledge. And from there, I got comfortable being uncomfortable in writing emails and meeting, senior researchers at different institutions to ask them to get engaged in the work.
So getting comfortable being uncomfortable is very good sign for leadership development. So and progress. Now going back to moving forward to where we are now, where are you with your research? And are you more interested in the clinical aspect? Because pharmacological treatment, we're going to early discovery even, or the clinical development, because I come from R&D.
Okay, yeah.
Different lifetime. So the question is, which is more of interest to you? Clinical research, preclinical research, new tools, and where are you with, I don't know if you're modeling or if you are building trials, or where are you now?
Mm-hmm. So
and we'll come just after.
Sorry, say that again. I just missed that.
We'll come to the funding of research just after that. Or if you want to incorporate it in your answer.
Sounds good. Yeah. So in terms of my particular interest, it is actually quite split, which is interesting. I do love that clinical component. And the goal of a lot of my bench research and early pharmacological studies is to get that translational component in there. So the pharmacological work is still ongoing, and we are preclinical with that work. So we're working on developing different kind of lymphedema models and ways in which we can model this disease. Again, it's under research, so that's even a challenge unto itself, creating the models that we're working on. And so that's that. I started with the 3 compounds 8 years ago, and one of the compounds I had picked a little bit at random, and I looked at the name and I was like, oh, this seems, maybe I'll try this one. And that, I kid you not, is the one actually I worked with, the only one that's left 8 years later. And it has shown, positive impacts on how the lymphatic system is functioning when damaged by something like inflammation, lymphedema. I'm now working on 2 different surgical projects, trying to look at the impact of reconstructing the lymphatic system after it is damaged either by surgery or by a more progressed lymphedema, which has been really quite impactful. And then this kind of quality of life and psychosocial work, which I did, my latest paper was focused on psychosocial implications of this disease, kind of looking at that aspect of things. And I absolutely loved running that study, and it was a mixed method study. So I got to speak with many people, which I think in a sense was almost therapeutic for me as well, speaking to so many people impacted by lymphedema. And what we were able to do through that work was not only demonstrate through metrics the substantial quality of life and psychosocial impact of lymphedema on patients, but then also develop actually a healthcare delivery model for people who are impacted by lymphedema based on our qualitative work. So we spoke to healthcare providers and patients who are either, again, treating lymphedema, see it in clinic, or people who are living with lymphedema, and developed this wonderful model that has 6 tiers to it that demonstrates, an optimal model of care, including things like lymphedema education, the screening and diagnosis, resource awareness, the importance of clinical referral and resource accessibility, the importance of continuity of care, and then the psychosocial support in addressing a very common fear of cancer recurrence with these patients. And through this work, I think also found a passion for this stuff, definitely. But it really emphasized the financial disparity that many patients are facing amongst other challenges. So yeah.
So thanks for those, because we have a very mixed audience, I think. So just to give people an idea, there is a component of discovering a molecule, the component of what we call R&D, which is doing the trials and seeing whether it works on a small scale and then on a bigger scale. And then addition to pharmacological treatments, there are other things like reconstructive, and we have wonderful new materials and, tissue developments and so on. And of course, then there's the component of delivery and also studying QOL and economic and so on. But for all of this, because these are very different types of research, you need very different skill sets, which one can acquire over time, but also you need very different types of funding. So my question to you, this is another research area, much as it was, for example, Alzheimer's for women, and because it impacts upon women much larger. 20, 30 years ago, little progress, little funding has gone into that, or many other diseases. So the question is, what did you do about funding, and where do you see yourself? I know it's a very expected question, but okay, in discovery, maybe you have to start from scratch, and that's okay, because if nothing gets lost in terms of learning. But where do you see, which one do you see focusing more? Do you want to continue with across modalities, or do you want to focus in one area as more impactful?
Yeah, so I actually do get that comment or question very much so, as you've gone. Yeah, you've spread your wings in very different ways, and that is through I think a lot of collaboration. So going to teams that I knew had obviously expertise in these different areas, and becoming part of that team, and basically creating a network that way. And so from a funding standpoint, I actually started writing research grants when I was 15. I started developing that skill. And so these were smaller still things that were either smaller scale grants, like Young Innovator and Young Investigator type of grants at, say, a cancer center was, I think, the first grant I had written, all the way up to kind of a more national based grant. I think I'd written one I was 17 or so. And of course, had wonderful support from my mentors who were our senior researchers again. So kind of learning along the way, but trying to do my best in leading these different efforts. And then having support also from people's labs who were very gracious in supporting me that way. For my own future, it is hard to say. I think I will always try to keep a hand in each area, and if that is through kind of team development, then I think that's something I see myself doing, is always trying to build those networks and move things along. I think that there is a need for a pharmacologic researcher as well. In Canada, we have a wonderful group in Toronto who has expertise in kind of the mixed method research and the quality of life work. Some people who are have their expertise in the surgical component, and a couple other aspects of lymphedema. And so that's one way in which I could see myself fitting in, though the jury is still out. I think have a couple more years to. Sorry,
yeah, but I mean, I think it's an area where you can do that. I think we see more and more people, but I mean, it was considered sacrilege to transition from the lab to public health, or vice versa 20 years ago. Now it's happening. Yeah. Having a finger in every pie, yeah, and speaking also for myself, but also, do you think, I mean, you mentioned mentors and so on, so to also link it to speakers coming up, do you think it's important to have more women doing peer-to-peer support at every level, not only academia research, or do you think it's okay just to build support networks? So there were any particularities that as a woman or young girl that you found more relevant, or do you think it would have been no difference? And of course, there's the stereotypical argument, cooking twice, but then again, maybe all three of you cooked, but I'm just asking. Yeah,
no, I have had both kind of male and female mentors over the course of my journey, and have learned wonderful things from each of them. I can certainly say something I've appreciated in some of the mentors I've had who are women is kind of discussion of the barriers that they have faced as women, and we talk about the glass ceiling and breaking through that type of thing, right? And these are things that I have now, despite being early in my career, certainly have experienced myself, these barriers. And so having mentors to be able to discuss this with and how to best approach it has been extremely impactful. And so, yes, I am a strong advocate for mentorship from both female and male leads, because I think we have something to learn from everyone, as we heard in an earlier talk, right? But yeah.
So thanks very much. I think I would like to ask more things, but we're well over time. Thanks very much for joining us. I hope that we will be able to come back to you and hear more about this in terms of practical, what you found more relevant across your journey. I don't know whether, Liz, do you have any questions, or do we have any other comments? I don't think we have any questions. At least I haven't seen anybody. Yes or not? Give me 1 second. So Liz, it's on to you.
Yes, sorry. Thanks, Elaine. No, there's no further questions at the moment. But I just want to add, thank you so much, Catherine. And it just sounds like you've done an immense amount, and I'm sure your family are just so proud of everything you've done as well. It's truly inspirational, everything you've achieved, and at such a young age as well. So hats off to you. Very well done. I'm going to move on and introduce our next speaker, if that's okay.
Yes, thanks, Catherine.
Thank you, Catherine. It's Dr. Margo Thomas, who's the founder and CEO of the Women's Economic Imperative, and she's going to be talking about her work today and on women's empowerment. Thank you, Margo. Over to you.
Thank you. And may I share a screen? Can you hear me?
Of course, yes.
Yeah, sure.
Of course, you can share your screen, and we'll tell you when we see it.
Okay, so I need to put this on. Yeah, there we go.
Perfect. We can see it, and it's in slideshow. Thank you.
Okay. So first of all, let me say thank you to the organizers for inviting me to be part of this discussion. I think the topic and the whole issue is very timely, but I also want to discuss it from the perspective of the opportunity that this particular point in time presents. I also would like to say, as an alumna of the University of Manchester, that's where I did my PhD, it's always nice to be back home with people with whom I share something and have something in common. So very happy to do this. Oh, there we go. I just wanted to say a couple of words about Women's Economic Imperative to give some context to why I think this discussion is so important. So I spent most of my career working on economic development, social and private sector development for economic growth and inclusive economic growth. Towards the end of my career, I was appointed, so I worked in the World Bank for most of my career. Towards the end of my career, I was appointed to lead the Secretariat supporting the high-level panel on women's economic empowerment by the UN, and this was a UN Secretary General high-level panel, so it was an initiative of Ban Ki-moon. Coming out of that work, where we focused on women's economic empowerment, which is a subsector of SDG Goal 5, but it was seen as a driver for women's empowerment more broadly. And so Women's Economic Imperative, you can tell the play on the name, it's recognizing that we really need to focus on this. At the time, we were all looking at the SDG and the goals for 2030, recognizing that we are way behind schedule. So WAY was established to focus on a couple of things. One, promoting women's entrepreneurship as a driver for economic growth, but also a key to this whole concept of empowerment, empowering women, because many of the systemic and structural barriers that women face in the economic space can also be a lever for addressing some of the social and political issues. And so we do this work by influencing action, driving change, and actually undertaking some very what we hope are innovative initiatives to unleash the women's entrepreneurship in the economic space.
For some reason or other, my pointer doesn't work as well as I would like it to. I don't know why. Sorry, I'm having some difficulty. Oops. Okay, here we go. So in framing my remarks, I want to make a couple of points and then link it back to the health issue, because at the end of the day, we're really talking about health. First of all, to use a catchphrase, women and girls matter. And the reason why I think it's important for us to say this at the beginning is because I think when we talk about gender equity, it often becomes an emotional or social discourse. And I think we need to take a step back and recognize a couple of things of what we mean when we talk about women and girls. First of all, they're not a homogeneous group. They differ across race, geography, culture, but the issues that impact women and girls and across history, the way in which women and girls function within societies, there are commonalities across all of these differences. So in fact, many of the issues cannot be looked at as developing country versus developed, North versus South, because the reality is that these issues are present globally and in every economic system, every political system, every cultural dynamic. The same issues can be found. So I like to broaden this discussion and say women and girls constitute a subset of a global majority of underrepresented and marginalized people, because it's the underrepresented and marginalized who, as a larger group, are faced with the same issues. My third point is that the gender equity is not a woman's issue. It's everybody's issue. And I think we need to change the calculus around the discussion of gender inequity, because men are equally impacted by these inequities. They just may not see it that way. And if we can get that message across that everybody benefits as a result and change the calculus, maybe we will get more movement in terms of shifting the dynamic around women's equity. The fifth point I would make, since we're talking about SDG 5, is that it's transversal. It really cuts across all of the other SDGs. So, having said that, I believe that the essence of empowerment more broadly then is really about the power of voice, representation, and agency, the ability to act in your best interest or in your own right. And if you look at it from that perspective, then I hope you will understand why I say that this is an issue for all underrepresented and marginalized people, because it's the same fundamental issues that we all face. How do we address this then? I think as a starting point, we need to recognize that as human beings, everybody is created equal, everybody has dignity, and everybody has value. And as such, we are all mutually vulnerable, in the sense that if the pandemic hasn't taught us anything else, if the person at the bottom of the line or the bottom of the food chain is not healthy, then no matter where you are in the food chain, we're all vulnerable. Now, I come back to the issue of dignity and value, because when it comes to the discussion in the health space, we had the first presentation about the women who have been afflicted in a particular way, focusing on sub-Saharan Africa. And it helps us to understand how women can be devalued through no fault of their own, how through a cultural lens, they are blamed for things that they have no control over. But we need to change the perspective on this, and it has to be done as a community. There's need for broader action and a broader recognition of these disparities that persist. So let me flip a little bit, and I'll go very quickly through why I believe that the COVID-19 pandemic response, recovery, and resilience offers us an opportunity to really drive home why we need to shift the calculus. Marginalized groups are more likely to die because of the COVID-19 virus. In the UK, Black women are 4.3 times more likely to die than white women. In terms of women being disproportionately disadvantaged and impacted, bearing the costs and risks of the pandemic, there's been a tremendous increase in female poverty as a result of the pandemic, the economic impact of the pandemic. Close to 1 billion women work in the informal sector globally. This is in the North and South, so this is a global figure. Their income fell by 60% as a result of the pandemic. The gender poverty gap for women increased significantly by more than 20%, so that for every 100 men who are below the poverty line, there are 121 women and girls who are affected. Females comprised 70% of the global health and social workforce, and invariably they were the majority of the frontline workers. Migrant women have been affected because many of them are considered not legally residing, particularly in the northern countries. As a result, one can surmise that more women over time will die as a result of the pandemic compared to men. The issue of unpaid care and domestic work, because of the inherent balance within families, the burden on girls in particular has shifted. And then the commoditization of women. More women and girls are being trafficked following the pandemic. More girls are being forced into marriage or unsanctioned situations in which their bodies are taken advantage of. And women's access to health care has diminished because of the shift in resources to respond to the pandemic. And this is a global issue. So I think if we can recognize that while women have been disproportionately impacted along the lines that I've outlined here, at the end of the day, because of the long-term and the intergenerational effects of this trend, it's everybody in society who benefits, because it will take us longer to recover from the economic and social consequences of the pandemic. And we cannot increase our resilience against future shocks, whether they be health, environmental, or other, if we do not focus on building our human capital base more equitably. So there's been talk about the issue of violence against women, and I want to really not omit that, because we tend to think of violence, and it's good for us to think of it in a health context, but it also has economic and social consequences. And these are long-term consequences. So to close, because I know that time is short, I believe that if we can come together across different disciplines, across interest groups, across genders, so we need to include the men in this. And if we can come together to address the issues of representation, voice, and agency, recognizing that power and control will continue to be an issue if it is not equitable. It's not sustainable in our political context, in our social context, especially if we have these increasing inequities in the distribution of power, in the distribution of wealth, and it's not in the world's long-term interests. We will continue to see the kind of instability that we all are aware of based on what we read in the news day to day. So my take on this issue at the end of the day is I would like for us within this space to think of this discussion today in particular, this is the only panel on which I've been speaking, as the beginning of a discussion in which we can come together to address the issues, not just in the health space, but more broadly, in order to have a more systemic and structural response to the inequities that are evidenced in the world. Thank you.
Thank you very, very much for this very comprehensive presentation. Sometimes people hear, I mean, it was a very dense presentation. People may hear a word about increased trafficking, which means little, but when you narrow into the data and you also get experiential accounts, it is daunting. And I think also speaking from my own background, because I move from research to policy more and more, you get lost because policy discussions are, let us say, more distance from the field and from practice. So I wanted to ask you, I do not know, I'm assuming that you must have been involved or aware of the forum that we had on the 2nd of July with France for women's equality. I do not know if you're aware of this. The UN women were very active, and Macron and Kamala Harris, and we had a delegation in Women Global Health of 170 women. And I have to say that the energy was quite superb. For me, it was quite disappointing to see women from Europe, very, very few, very underrepresented. But the focus was, you mentioned refugees and migrants and trafficking, and these are critical topics and they're on the rise. I mean, the trafficking data is abysmal, and for Europe, it's 1 in 3 migrant women is actually either a victim of rape or gender-based violence, which is, it's ridiculous because it's Europe, and they're not reporting and they're not doing anything about it. So going down, I mean, in on limited experience, research experience, it's very much coupled how you behave in terms of moving from such situations. It's very much linked to the means to do so. So empowering women is not just speaking to them, is also giving the means to live independently.
Absolutely.
And investment, financial investment, has been very limited. So we have seen philanthropic initiatives, we have seen multilateral bodies, but structural investment from governments has been very, very, very limited. So my question to you would be, what do you think is the most relevant actioning at the moment? And is there a role for multilateral bodies to that effect, or should it be done at national level? So what's more important? National actioning or international collaboration for economic empowerment for this women?
No, I really think that it has to move on parallel tracks, right? There is a role for the international community. Anytime you have, for example, issues of trafficking, movement across borders, that's bigger than any one government. And so we need to come together on that. So, and there's equal responsibility in the countries that receive, as with the countries from which people are departing. We also need to look at the role, why. We need to get to the why. Why are we having this kind of movement? And what are the triggers? The pandemic, you could say it's one, it's caused an uptick, for example. But also, we can't miss the environment, where communities are losing their ability to sustain themselves, and therefore they need to look elsewhere. It's not just economic migration anymore. This is a bigger issue, right? So, which brings me back to my pitch every time I talk now is really about reframing these discussions. But I want to be a bit of a troublemaker when it comes to trafficking. You see, we tend to think of it as a developed versus developing world. Yes, that's the manifestation today, but put it in historical context. And then what I want to challenge is the social view of trafficking. You know, depending on how you define it, you could say that in history, one of the best examples of trafficking occurs within royal families, where women and men were moved around. They were trafficked across borders and across royalties for economic and political gain of those who have power and control. See, I'm using the same words. And so in many respects, many of us are complicit.
Of course,
either through our silence, through our active participation. And until we start to reframe our understanding of the value and dignity of every human being, these patterns will persist. But again, in every situation, women and girls often are more disadvantaged. And this is what I mean about structural and systemic inequities. And at the end of the day, they affect us all because we are all less than what we could possibly be if we are willing to challenge these notions. It's difficult. So, and it takes time. But if somehow or other we can wake up this awareness in every human being, that's where we're going to begin to make a difference. And for those of us who are involved in this conversation today, you see, she's really talking about something huge. We can't tackle it. Come back to the analogy of the elephant. You have to eat it one bit at a time, but I will take it further. Actually, the first change must come from within each and every one of us. To eat the elephant, you have to decide that you're going to eat. That's the point of intervention that I think we all need to make for ourselves. Then we can begin to influence the people next to us, the people within our networks, within our communities, and then we can create a momentum for change.
Thank you. I don't think you're a troublemaker. I think you're discussing topics which are critical for all of us. Even if we don't discuss trafficking, if we discuss perception of how women behave, loose women, prostitution, HIV links to these concepts. It's even for very educated women, we all have inherent biases, and they go deep down, even if we're not aware of them. So, I mean, would you argue that perhaps not only at university level or after university or research level, do we need to go perhaps at primary school or secondary education? And it's a literacy issue, but not only, it's also an issue of grassroots activation community. So what would you think is more relevant? Start with children or start with people that are having a more active role in community? I mean, we see, for example, in rural areas, religious leaders having a lot of impact on how people are perceived and stigma. Religion is still a very big factor across the world in most countries. Political leaders also, how they behave, how they embrace. So what do you think is the relevance of that?
Again, I'm going to say the same thing. We've got to start.
Small.
It has to be multi-pronged, right? I don't think we have time now to take an incremental approach on many of these issues. It's another benefit of the pandemic, right? It's all hands on deck. But if we can't start with ourselves, then the rest of that, you know. You mentioned, for example, the perception of women and who determines, so it's cultural, who determines what kind of behavior, it's influenced by religion. Yeah. But, you know, what we have embedded in laws are really based on norms and these acceptances and understandings and perceptions. So you may have seen in the news just last year in Croatia. I lived in the Balkans, I pay a lot of attention there. But in Croatia, there was this upsurge of complaints about gynecologic violence against women, right? And women who were seeking care, again with the pandemic, but this judgment for women that those who were treated with dilation and curettage, it was done without pain medication. Because there was a judgment, if you needed it, then you were a loose woman. That's the inherent, right? Or it's your fault. Yeah.
Yes.
I highlight that to say how systemic these issues are, and the issue of bias that transcends these societal features. But in the space of health, I think we can keep coming back to it, because the reality is that these are those decisions that get made by people without even thinking because of their particular leaning or interest or how they were raised. Your question about should we start with children? Mm-hmm. Yeah. And this is how it impacts women in the current space as a result.
Well, you mentioned the Balkans. I mean, I'm Greek. I've been abroad for 30 years. I still, for example, Greece cannot decide where it belongs. South, west, up, down, conservative, progressive. And of course, there's a huge gradient, rural, urban, very different perceptions. Mm-hmm. But going to the practice and changing everything that we have done for behavioral change in Crete, it doesn't last. It's very successful for other topics also, but it doesn't last long. It lasts as long as the intervention is in place, mm-hmm. and a little bit longer. And then when we see this 2-3 years later, it has reverted. Yeah. So that's why I was asking about investment and more structural means to have their established mechanisms for change. Yes. There was also a question, I think, in the chat before I passed to Liz, but thank you very much for raising key issues. And let's see what we capture in writing for the report.
I'm trying to be provocative. Hopefully people will go away and think about some of these things a little differently. That was my goal.
So the question was, I think, do you think that governments need to adopt quotas to make representation happen? I think it has happened in some countries. Yeah. Mm-hmm. And before I let you to answer the question, I will say that EIGE, the European Institute of Gender Equality, will be producing a new index which has a health modality in October, and we will have it in November in the European Public Health Conference in the panel for women, because I'm chairing the SDG group there. So if you put EIGE and you look at your country, of course, for European countries, you will see that There are different modalities. What correlates best to how equal things are across sectors is representation in the political leadership. And Greece is actually the lowest of all European countries in these two overall. So passing the ball back to you, Margo, if you want to answer to this, and then I think we go to Liz. So.
Yeah. So you asked about quotas. I think quotas have their use, but I having been around the block, I can also see where you can get unintended consequences or where they can be manipulated. And so we can't stop at quotas because then they can become a band-aid and we can't avoid doing the hard work. And so we've got to get more into the structural and the systemic factors. But your point is well taken. And remember, you know, there's this talk about women as problem solvers. And we see, I've got to give kudos to the Secretary General who came in. I was there in the changeover. The panel was empaneled at the time. He committed to recruiting female leadership across the different UN agencies, and he's done a great job. So it's wonderful that in the pandemic response, we've got women involved at that level, but sometimes it could be a bit of a trap. So the expectations are so great that there's no way that you could win. And then it gives an excuse to not recognize that we need to move on different fronts and we need to get a broader stakeholder base, including the grassroots.
Thank you very much. I don't mean also to sound provocative, but yeah, women leaders did do a little bit better, let us say, from men. And yes, in the UN, there was representation across the board, but in the committees leading for COVID across the world, it was not women leading developers.
Exactly. So there's my point. That's exactly my point.
Yes, but I had to reemphasize we become a little bit controversial, and they have been in an inordinate amount of expectation, left wing, right wing, irrespective, on women leading. Yeah. Always, you have to outperform. But thank you very much. And Liz, it's on to you. Forgive us. This was very interesting, extra interesting. So thank you very much. Thanks, Margo.
Thank you.
No, completely forgiven. And Margo, I think you would have probably had a standing ovation there had we been in person. So no need to apologise. Next, we have Dr. Yonette Thomas, who is the founder and president of Urban Health 360, and she's going to be talking to us today about women's urban health. Over to you, Yonette.
Yonette, we can see your screen, but we can't hear you. I think you're still on mute. If you look on the bottom of your screen, bottom left, you should be able to unmute from there.
Now?
Yes, thank you.
Okay, sorry. So let me get out of my slides. I apologize. I have to say, I want to say thank you. Thank you for having me. And as an inside, I always say, and I have to request next time if this happens, don't let me follow my older sister, because then it's really difficult. But that said,
we didn't highlight these aspects, but okay, if you want to.
So I'm just going to switch gears as an epidemiologist and talk about urban health and the context of the SDGs and the need for change involving women in urban health. So bringing us back to the SDGs and recognizing that urban health sits in the middle of all the SDGs. At least 48 of the targets are relevant to urban health, whether you're talking in this instance about health in general, SDG 3, and then all the SDGs that relate to women, SDG 5, and all the other structural SDGs. So when we think of urban health globally, I'll start with Africa. the issue of urban health, as we know, there's a demographic transition occurring as we speak. 60% of the populations by 2050 will be living in urban areas. Most of this transition is happening in Africa and Asia, and in the context of Asia, in India in particular. So there are issues of the structural issues of lack of access to sanitation, environmental issues, flood vulnerability, the urban sprawl, and governance. And when we look at Latin America, we see the similar things happening. It's urban health, urban populations, people living with issues of high degree of malnutrition, the excessive growth of cities, not ready, not having the infrastructure to absorb the people migrating for economic reasons and environmental reasons into areas where they're more access to care and structural things. In Europe, we're seeing not different change. And we have migration, we have an aging population, which is in Europe, it's a demographic time bomb. The bulging of the population on one end without the lower end to sustain it. And we're dealing with all the environmental factors. So this urbanization and its link to population health is across the globe. So what does the landscape look like in terms of the SDGs? Well, the SDG, the focus on leaving no one behind, we, in thinking of urban health, in thinking of how they link, goals 3, 5, 8, and 10 really are the main drivers, but they all have an impact on urban health. And then when we start thinking of the health of women. So these serve as action points for focusing on the health of women as an economic value for the robust development of communities, municipalities, and cities. And I always, as an epidemiologist, I always get excited when I listen to economists like my sister and political scientists, people like the head of the IMF, who talk about we cannot have, because of COVID has exacerbated and highlighted this, we cannot have economic discussions without focusing on health, without engaging epidemiologists and others. And the realization that health of women is an economic value. It's not just simply, it's health, yes, but it's related to economics. Because if women are healthy, the communities, the family's healthy, the community's healthy, the country, the globe is healthy. So this is exciting to hear organizations like the IMF saying things that we, as population health scientists, have been trying to articulate for decades. So everybody knows this. Women comprise 70% of the global health workforce. Women are more exposed. We've heard in all the presentations up until now, and women earn less than men. And women are the caregivers, the providers. Everything hinges on women. So this is a global issue, and COVID-19 really has re-highlighted this for us. So one of the things I want to articulate with this quick presentation is the importance of valuing the health of women and girls. Women and girls stand at the end of the healthcare queue always. We need to invest more. Increasing investment in their health is not only the right thing to do, it is critical for stable and productive communities. Providing basic health care. We heard about the fistula issue and all of those. That's one of the multiple health issues that impact women and go unaddressed because, well, it's women, they'll get over it. We have to move on. They need to provide care, but they also need to be cared for. And so things like family planning, it becomes a social and religious dialogue, but it shouldn't be. It should be an issue of health and economics and social well-being. So we really have to, as Margo said earlier, reframe the issue. These are systemic issues that we all, I know we're preaching to the choir in this environment, but at every level, our colleague from Calgary talked about she reacted to an issue. It was a health issue, but it was also an economic issue for the family, and proceeded to do something about it, and make a difference. So in taking action as we go forward, recognizing, using COVID-19 as a bellwether, and recognizing that it's one of the many shocks that will impact us over the coming decades, public health preparedness and response plans should consider both the direct and indirect health impacts on women and girls always, not just the men and boys, not just people at one level of society. And we know that through United Nations recommendations, the need for the adequate response, we need to, in doing this, we need to target public health messaging to women and girls specifically, and really address the specific needs of women as frontline workers, whether they're in the care economy, whether they're healthcare providers, whether they're physicians providing care. What we saw here in the United States was abysmal. Women physicians, women healthcare workers, women nurses were differentially impacted. They had less of what was required to provide more care in a time of crisis, epidemiologic crisis. So the resources and the standard health services for women at all levels of the life course is very important as we think about being ready at public health, prepared in a public health context for coming shocks. And it is very important to recognize that addressing gender inequities yields, from my perspective, I have here a triple dividend, because health will bring quality and accessible care to more people. Gender, recognizing and rewarding and facilitating the integral role of women in the care economy as health professionals, as unpaid care, unpaid care provided by women and girls in households, and the underpaid services provided by women in the informal sector. And economically, if we address this, more jobs, increased productivity, and economic growth, not just at a national level, at a community level, at a subnational level, and at a global level, regionally. So this awareness and this talking, bringing health and economics together with broader public health focus and preparedness is so critical. It's nice to see that this dialogue is happening at the multilateral level, at the global level. I'm hearing more and more. As I said, the International Monetary Fund, headed by a woman, is articulating this. We've got other women leaders who are saying, recognize this, again, the importance of having women at the helm, but it has to be up and down the stream. So from an urban health and a health perspective, I wanted to bring this to this conversation, and recognizing that we're short on time, just a few probes to get us motivated and to continue the dialogue and thinking on these lines. Thank you.
Thank you so much, Yonette. That's a really excellent presentation. And can I just say, I didn't know Margo was your sister, and I'm sure next time we will accommodate as you wish. We've had an excellent question. There are some great initiatives that focus on women's empowerment in informal urban settlements, and these often go on to provide widespread positive impacts in these areas, but these are often discrete projects. Do you have any suggestions for how we scale up these empowerment initiatives? Because as you said, this has a wider positive impact than than just with women?
I think as public health, and I'm a population health scientist. As population health scientists, we have to recognize that it's yes, and I commend and applaud those initiatives. We have to keep doing them, but also think of them on a broader scale. We do it, and the realization that what happens in the global South. If you take the excellent presentation by Tina on fistula. That's happening in the global South, but it's also happening in rural communities in the global North. So it's this bringing together of the learnings, South-South learning, South-North learning, North-South learning, and really seeing how that this is a mosaic, and we're talking about the same population group wherever we are, women and girls, and going with the notion that healthy women and girls really makes a fundamental difference and is a benefit for society in general. So scaling up, I really think comes through the collaborative thinking. You may be doing a project over here, sharing that, recognizing that it has direct linkages to other regions. So it's really us coming together and thinking and sharing and collaborating and the cross dialogue and the cross fertilization of these ideas is really critical in helping and seeing this not just as a South issue or a North issue, it's a women and girls issue, it's a global issue. I say, I have this mantra when I talk about urban health, people say, well, it's urban health that's over here. No, urban health is a microcosm of global health. And so you have to see it in that way. It's health for all. And when we talk about health, a number of my colleagues, as I talk to them, and said, it's not just, health is not just healthcare. Healthcare is one piece of it. It's health and well-being. So you have to see that health is a holistic platform that involves mental health. It involves well-being, feelings of empowerment. That's why economic empowerment is so critical to health, because the more empowered we as professional women know, we're able to speak. And I think someone had a quote from Meghan Markle, which was, I didn't know that she had said that. It was very profound. It's allowing the voice to come through and allowing the recognition as women in research, as women professionals providing healthcare, making sure that our research meets the policy and sinks into policy. So when we are in policy discussions, listen, this policy is informed by the research we're doing here, and here is why. And that whole really making research to practice, not just a thing we talk about or we add to our proposals saying we're going to do that, really making it a standard. I keep going back to Tina's presentation, using the engagement up and down the line to really filter and inform our research and inform those around us as to why our research is so critical to change the dynamic in communities and in countries, in regions, and in the globe.
Yes, completely agree with you. And I think there are so many cross-cutting issues, aren't there, as you say, particularly the representation of women globally and the cultural representation of women. And yeah, completely agree with everything you said. Thank you so much. I'm now going to hand over to Elena to introduce our next speaker.
Thanks, Liz. I mean, first of all, to say thanks to everyone. We are going to be at least 20 minutes over time. And so thanks for bearing with us, to everybody that's bearing with us. But I have to say that I mean, if you notice, all our speakers are very passionate about what they're speaking, which you don't get in many medical or health events. So hopefully that's a good sign. So the next speaker is Catherine Kronacki. Catherine, I cannot see you on the, yeah, there you are. So Catherine is very happy that Catherine is here because she's a fellow Greek and she has been a colleague and a friend and a very dear mentor, and also she's Cretan. So Catherine is the president of the European Federation of Medical Informatics. She's also the general secretary of Hl7. For those more involved in healthcare, Hl7 is, let's just say, the widest, the most widely used standard that we have to link systems and to be able to make sense of interoperable tools. And she's been also, we've been involved together, but also she's been leading many, many activities that have to do with interoperability, from very recently exchanging vaccination records, which you all probably know or have heard about, but going back to 12, 15 years discussing how to link US and EU systems when I think it's already 12 years, Catherine, when we had the EU-US sign off of the Memorandum for e-Health. And she's also involved in many other activities. But today, I mean, and the reason we thought she should be a good fit in this panel is because we have been trying between the European Public Health Association, the European Federation of Medical Informatics, and also within EFMI, so the European Federation of Medical Informatics, to broker dialogue for diversity for the past, I think, 4 years. So I'd like her to give a little bit of insight, because if there is a profession where women are encountering biggest barriers than they do in science, that's engineering. So thanks for coming on board, Catherine, and for sharing insights.
Hello, everyone. I'm very happy for this introduction. And I must say that I am a little bit of the oddball in this panel. I really appreciate this invitation and also hearing from you, because this is talk that we typically don't hear in engineering or STEM areas. We are mostly thinking of the digital and how to create software programs and how to make them speak to each other, how to exchange data. But all that is there to serve you. And I will be speaking now today to mention two main things that are in the digital. The first one is how we work together. So I will speak about our initiative with Elena and other people about mentorship and peer relationships. And the second one would be One Digital Health, which is a new initiative that we have started in EFMI. And it tries to use the digitization opportunity that we see in COVID to connect all the different types of technology that we meet in our life under the umbrella of health. Because like a previous speaker said, it's all about health. And health and wellness are what makes it worthy. And as women, we give birth and we grow, and we are very much tied to the safety net of the society. But we cannot do it alone. We have to make the connections with men, with non-binary people, and make it happen. In any event, let me share my screen to give you a couple of points. I will be much shorter from the previous speakers because I feel that there are a lot to say, but we cannot absorb everything now. So let me share my screen. So, and
not yet, but getting, yep.
Yeah, this is just to start a discussion, like we said. So this is some work that we did with Anne Moon, which has been my mentor, with Elena Petelos, Despina Bulgaraki from the industry, Eva Turk from the industry and the academica, and Yurali Neol, a PhD student experiencing. So you see us there in MedInfo in 2019. As Elena said, it's been an effort to make this happen. we are there with Susanna Bakken, you see here at the end of the line, who is from Columbia University and has done great work to bridge some of these gaps. So myself, I'm Cathy Kronaki, I'm with standardization. So it's about how we connect, how we exchange information. So this is my passion. And also I'm the current president of the European Federation of Medical Informatics, which tries to link that to nurses, to health professionals, and make this information part of the daily living. So this is a picture of Hl7 Europe, which I lead. We have 23 organizations that are national organizations, and we engage very much in EU policy. EFMI on this other side is the leading medical informatics professional organization, 28 countries, many working groups that address technical issues, except perhaps on education and one digital health that I mentioned. And the goal since 1976 has been predominantly the same. It is to advance the health and science in health, the science and technology in health in a European context. And we work very closely with EMEA, which is the International Medical Informatics Association. Previous speakers talked a lot about the Sustainable Development Goals. What I would like to add to the first 4 goals, which we saw in a couple of slides before, is the 17th, the partnership for the goals. And this is my first key point, that we need to make partnerships. And we need to focus on partnerships because this will help the world get better. The second point that I wanted to make has to do with mentorship relationships. And I hope that we can formulate programs between public health and informatics and medical informatics that can advance this mentorship relationship. And here, as you see, mentorship relationships are about career enhancement. They can be direct mentorship from an older to a younger, or it can be reverse. And this is very relevant for the health sector, where we have a lot of people that are mature and are not very much into the digital, and where younger people can help them. So we have a kind of a reciprocity in relationship. I would also like to point out on the importance, especially in this online world that we are living, and I don't know if we will be soon exiting with COVID-19, of peer relationships, where we have relationships that grow, they last for a long time. Maybe they start from a mentorship relationship. They are peer relationships, one gives to the other, we share information, we strategize, we give feedback, and we support each other. And there is nothing more important than support in these unknown situations that we are witnessing with COVID. So in our collaboration across institutions, we saw a number of webinars and we asked questions like, what kind of initiatives does your organization do to promote gender equality or inequality for that matter. And here it was interesting because we took the stand that we need diversity. We need diversity to advance innovation, to fit the needs of the different communities. So you see workshops, mentorship, you see women in standards, which was an activity started in Hl7 International. You see leadership, you see the Girl Day workshop. Yes, but I think you see also something else that is very important here. You see the mixed teams. And one of the things that I would like to highlight is that innovation is in the diversity. So think closely when you reach out next time so that you include all genders. Yeah. So you don't close yourself into a women's cycle that you feel more comfortable. So get out of your comfort zone. And this is something we need to educate ourselves. Our younger colleague in the group shared with us an initiative in Paris, in the university, where they have monthly mentoring mentee meetings. And you could also think how much we offer here, and we offer in terms of diversity, in terms of advancing innovation, in terms of supporting each other. The six P's of gender diversity strategy by Mercer. This is something we would like to underpin the activities and the collaboration across this multidisciplinary space. And you see here some very important points that Mercer first identified, that we need leaders at all stages to be engaged. So you have a multidisciplinary team that involves men and women, non-binary. You have also leaders at each level of their career. And in this space that is beyond the comfort zone, perhaps of everyone, this is where we grow. And this is where we think out of the box. And you see also the gender equality, both men and women engaged in the personal commitment, the perseverance, we're thriving to sustain changes and this changing world like what we live with COVID-19 in the last years. And then of course there is the equality and the equity in the talent practices with pay, promotion and performance management, where we need to be persistent and we need to be actively pursuing processes that can help us grow and get what we deserve. And then, of course, be able to have programs that support the specific needs of women. And that goes to the previous speakers so much. The second one was when we asked, another question we asked in these webinars, multidisciplinary that we had is, what can we do? And you see one particular point is collect ideas. Speak to young people, set up indicators. And I know that perhaps quota do not help, but there must be a way that we can push the system out of balance so that perhaps the next stable condition is appropriate. So with FME, we connect this diversity initiative with the young FME group. So this is a group to support the early stage professionals. And we hope to integrate with that also the activities and the collaboration with public health. So to close, in this ever-changing healthcare environment, we need to empower women for leadership roles. And it is vital to sustain innovation and stay ahead of times. And that involves reaching out across age, across gender, across positions in the organization. And for that, these professional organizations we have available are extremely important. So this is the team, and we need some more. Thank you very much for your attention.
So thank you very much, Catherine. I'm going to go very fast and say that we started discussing intersectionality recently. We didn't discuss it today a lot, but it was the previous plenary. There was some interesting discussion in terms of role models, neighborhoods, what do children aspire to and what they see. So my question would be now for the next steps. What do you think? Do you think you could have a common agenda, TEFMI and AMIA and the global fora for medical informatics? And also something we have not discussed, but it's becoming pervasive for those of us that are more involved with digital tools. Do you think we are at risk of reproducing biases, including in algorithms? And
yes, the female AI.
Yes. So, I mean, perhaps you can explain a little bit what we've been discussing in terms of how we go digital too fast, and not from an ethics perspective, but from a practical perspective, we are risking reproducing some patterns, if you like, of how we deliver care, how we conduct research, how we diagnose, and how we prevent with tools that are geared, if let's say, not to factor in different genders and different types of people.
Yeah. So thank you very much for the question. It was actually in my notes, but in the interest of time, I didn't look at my notes, so I missed that. Female AI, yes. So many of the things that we do, the technology that we are encountering is based on algorithms, and the algorithms are based on data. having high quality data is fundamental to the performance of the algorithms. Yeah. So what does it mean, good data? Good data means that we don't let anyone behind. So all the different groups are well represented, are balanced, so that the algorithms bring good results. So in Europe, there is the European Health Data Space, which is looking at data and services for primary use, like healthcare, provision of healthcare and services and protocols and so on. But also secondary data. So how do we reuse the data? And in fact, there is a big discussion today of how you can link the two. You can link primary healthcare, so primary creation, generation of data, with the secondary use of data. Because if we do that, and we do that in a way that preserves trust and privacy and security, then the actual secondary use of data will be more reliable and trustworthy, because you will have richer data and more representative. So this is a big discussion today, and it is also linked to this this point that we have here about diversity. Female AI is exactly that, to make sure that the women's needs and the women's profiles are not underrepresented. They are well balanced and there is no bias in the algorithms that are presented. So to go back and to close, I think all these should be addressed, and I'm glad that I heard it in the context of Urban Health. It needs to be built into the one digital health environment, because only if we connect the medications, the environment, the technology, and the healthcare together, we can have this reliable data environment that can produce reliable and trustworthy results that can improve our lives. Thank you.
Thank you very much. In the interest of time, I'll keep it short, but I'll mention two things, because maybe they're obvious to some of us, but they're not to everyone, and for very reasonable reasons. So secondary use of data is any kind of use you have, particularly for what we have as health sensitive data, which is used for purposes other than the ones that it was originally collected. And although we have a very good, very comprehensive and also somewhat restrictive frame in the context of GDPR, with rare diseases, with smaller populations, with particular characteristics, you have to counter utilization, or if you like, really using this type of data for other purposes, and balancing, consenting, informing people potentially with low literacy level on what you're going to use them, because they have to be explicitly informed about that. So that poses a lot of consideration, but that really require both interdisciplinary collaboration and ethics considerations, particularly if you're going to deploy social interventions and so on.
Yes,
so,
and if I may, I have very strong opinion on that, in the sense that I believe that if we live in a data world where data matter, and data is about decisions that are important and affect our everyday life, there shouldn't be a notion of secondary use, because to make short what you very accurately explained, secondary use for me is research. Any type of research is secondary use. So I would think that research should be in every facet of our lives, and it should be directly on the primary data, and there should be the trust, there should be the algorithm, there should be the setup that makes this happen. Thank you.
So first of all, to say, Professor Lavender has to go, so thank you very much. I don't know, thanks very much, Catherine. I will come back to that, but because we're over time, Professor Lavender, if you have a key message and you want to share it, because we have at least 2 more presenters to go, I'm afraid. So please, if you are still with us, please unmute.
Yes, I'm still here, and I'm really sorry that I have to leave.
No, we are sorry that we're over time, but it's where we thought it was worth it. So
thank you. Well, I'm chairing another meeting shortly, so I do have to go. But I suppose for me as a researcher, I just think that we do need some more gender transformative research in order to empower women and ensure that they get into the positions that can make a real difference. So that would be my closing message.
So well said.
Thank
you for capturing everything I wanted to say in one sentence.
Thank you very, very much. I'm also having connectivity, so I've closed the camera, but thank you very much. Good luck with sharing the next session, and we will be in touch. And thanks for staying with us for 2 hours. Thank you. Thank you. Thanks. Okay, I think we need to really hurry it up. So Liz, I think I pass on to you for Arpana.
Thank you, Elena. Yes, so I'd like to introduce our very own Professor Arpana Verma, who's the head of the Division of Population Health, Health Services Research and Primary Care here at Manchester, and she's going to talk to us today about working in health. Over to you, Arpana.
Thank you so much, and thank you to Liz and Elena. If I didn't have rampant imposter syndrome before, I definitely do have it now. You've all blown me away with the fantastic work, your insights, your thoughts, and the way you've connected up all the dots. And so, yes, I'm feeling very small at the moment, but so pleased to be talking to you today. Just mindful of what Yonette said about family, and I think I dedicate this to our families, and especially our sisters, mothers, aunts. And I'd like to personally say a huge shout out to my mum and sister. And I think these are the role models that we grow up with, who inspire us, support us, and make us the women that we are. And being able to work with an amazing set of women here at the university, our research links, meeting Elena through our WHO links and UFA, meeting Yonette through ISUH, just couldn't ask for a better life, really. But I am acutely aware that how fortunate I am as having the opportunities that many of the populations that we are discussing today just don't have. And so I thought I could try to emphasize a bit of working in health research through an exemplar of our work with sex workers. And I think with all of the really important work that has been discussed today, the reason why I wanted to focus on this is that we have a very marginalized group who really exemplify all the things that you've spoken about: the exclusion, the domestic violence, the violence, trafficking, and the economic impact of sex work has been really emphasized to me. So my initial contact was really from a very medical model. So it was providing sexual health services, ensuring that we had all the right things for our sex workers without punishment. So if they identified themselves to us, then they wouldn't be prosecuted. And I have to very much thank Peter Elton, who was my first director of public health when I became a consultant in Bury. And he very much showed me the way with looking at the holistic picture. And I think we always forget in public health that's our training. I think we are interdisciplinary through the work that we do. Just it's sort of built into us and thinking outside the box. Whereas I found it that it's becoming more prevalent in our clinicians in terms of those that are then looking after populations. It feels like the penny's dropping, and we're finally getting the message across. So in our work, we focused quite heavily on trying to understand within the context of Bury, where it was indoor sex work rather than outdoor, what we could do to help. And this included some work on returning to mainstream employment and also hearing their voice, because it was just very intuitive for a primary care trust to think that the transition from sex work into normal paid employment would be as simple as, but if they want to, they'll be able to. And it was very enlightening talking to the board about the lived experience of sex workers and how we were able to really think through the fact that some of them wanted to stay in sex work. They really didn't feel the need to go back into normal employment, and as others would see it. And also the fact that employers just didn't really recognise some of the issues with having gaps in your CV. What were you doing here? And so with Peter and his leadership, we got some employers who wouldn't look at CVs in that same way. And then more recently, if you were at the Dr. Jana Memorial Lecture, Hannah with Tracy, who's in my team, have done fantastic work in India, and just wanted to really say about the huge loss of losing Dr. Jana, who basically has created an infrastructure of supportive measures for thousands, hundreds of thousands of sex workers and their children and families in Kolkata with such limited resources. And also, and this is again one of the key things that I've always felt is so important, is training the next generation. And that was always so important to him, whether it was nurturing our researchers or from other high-income countries that were coming to Kolkata under his guidance. And he very much was the voice, was the face of this marginalised group of women. And so I've been very fortunate to work with phenomenal women and men who just get it. And I think one of the things about getting it is never stopping. And one of the next things I wanted to touch on was our ability to work across the disciplines in a multi-sectoral way for capacity building. I can see Eleanor nodding because it's something we've chatted about. And how do we get education at all levels free at the point of contact? And so this brings me on to my next inspirational leader, that's Professor Dick Heller, who opened the People's Uni to make affordable master's level qualifications for public health. and he also founded the Masters in Public Health that we now are fortunate to be part of. And the next steps for me are to think about how we open this up. There is still a digital divide, and you'll see on the call today we have Kath and John, who've been phenomenal at ensuring the technology is there so that we can make our capacity building exercises open access and free. And then, the team led by Greg ensure that the festival is always at no cost or low cost to ensure that we can get people like yourselves to the people that matter. And so we're very much interested in how we can do this more. How can we bring this fabulous group of people that Liz and Eleanor have got together? How do we make it so that we can get your words of wisdom, the things that you've experienced out there, and your help in doing that through your networks, through your associations, are just so important. And I think we had very much a strong leader in our head of school, which is Professor Kay Marshall, who sadly couldn't be with us today, but will be recording a vote of thanks for the YouTube video. And there's a leader, if there's anybody to look up to. And so I don't want to really take up any more of the stage, because I'm very excited to hear Milena's talk. And I just wanted to say a huge thanks to Liz and Elena for what must be the most inspiring session of the festival. Thank you so much.
Thank you so much, Arpana. You are just an absolute legend, inspiration to us all. There is just one tiny question, if you would have a moment to answer that, please. It's really interesting to hear about the work in the PCT. Can you tell us how things have progressed since then?
Well, as you know, with the Health and Social Care Act, we went into local authorities, and sadly, many of us who worked in Bury had to leave. And so I haven't got an up-to-date update with you, for you, but what I can say, and I forgot to mention it before, Manchester Action on Street Health, just a fabulous resource that do such great work as part of the team that are looking after it together with the Drug and Alcohol Services. And I'm sure many of you saw the presentation by Jessica Allen from our Greater Manchester Build Back Fairer report that Professor Sir Michael Marmot did. I think this is one of the crucial things that Jessica demonstrated, was that unequal cut in budgets. And it's going to be the vulnerable people. And sadly, I think with Brexit, that I'm still devastated about, with the pandemic, with the impact of austerity, with the impact of the things that Andy Burnham was saying today, I really am very keen that we change over to action, because I think it's going to be the women and the girls who are going to bear the impact the highest. And whilst we measure other things, the one key thing I'm very keen to support, and Elena, I think you hit the nail on the head, is that being able to have Catherine here, is that data for action. because I think it's now that we have to come together and start doing things. And if I could ask for anyone interested in our poverty alleviation project, please email much@manchester.ac.uk, because we are a group of researchers, and again, the most fantastic women that I've ever worked with, Jane South, Anne-Marie Bagnall, to mention a couple, together with Catherine from our community setting in Manchester, as well as all of our fabulous team on the prior consortium. We've got to stop talking, we've got to start doing. And so this is the now. And working with our international partners is just going to be so important.
Thank you so much, Arpana. Thank you so much. I'm just going to quickly hand over to Elena for our final speaker of the day.
Thank you very much. But just quickly to say for Arpana, thank you very much. We have a lot of key messages that they're all important for data. Just bear in mind for people, Global South, South Europe, Balkans, rural areas, and so on, to get quality data, you need infrastructure. And we don't have that in place in most places, even if you get people to consent to utilizing the data, which people invariably do when they get to know what they're going to be, getting out of it in terms of improving their lives. People usually are willing to share the data if they know what they're going to be used for. But going to the last speaker, certainly not the last but not least, the last speaker is Professor Milena Pavlova, who is Professor for Health Economics and Equity. And we thought it would be fitting because most of the things we've been discussing are determinants of different sorts: socioeconomic determinants, biological characteristics, biological determinants, legal determinants, because legal epidemiology is very interesting, particularly in the context of COVID. So the last speaker is Milena, who is also leading at ASFER, the Association of the Public Health Schools in the European Region, the Economic Evaluation Group, and whom, when I was a little bit younger, I was lucky enough to have as a professor. So Milena, thanks a lot for coming on board and for staying with us for so long. And Milena has worked on different aspects of healthcare relating to women's health, maternal health, but not only. So, and she's also been involved as an access scholar in the Women's Forum. So Milena, thanks for taking the floor.
Thank you very much, Elena. Thank you all, and good afternoon. I'm really very happy to be part of this plenary session, and I can see that there are really a lot of interesting points that were brought, and I'm sure that there are even more that we were not able to touch upon during this plenary session. I would like to bring your attention to one group of women that are particularly vulnerable, and those are the pregnant migrant undocumented women in Europe, for example. I decided to focus on this group because they are vulnerable in so many different ways. These because of their pregnancy, because being migrant, and because being undocumented. I just want to say a couple of words about the challenges that those group of women are experiencing, in particular with regards to the use of healthcare in Europe. Although we know that European countries have very well developed healthcare systems and having very good coverage, they are not able actually to cover well that group of women. First, just to be on the same page, undocumented migrants, in principle, migrants who did not receive asylum, so rejected asylum seekers. They can be also the one who are overstayers because their residence permit has expired. There could be also people who enter illegally, but they could be also people who are forced to enter illegally. We could think about trafficking, which was mentioned earlier. So it is important to assure the health status of migrant and also of undocumented migrants because of human rights, but because also it also is an indicator of inequity in the countries. So mental health, maternal health is also essential in that regard, and pregnant women being documented or not documented, being a migrant or not a migrant, have the right to good health care. Evidence suggests that undocumented migrant women, they use healthcare much less than any other migrant group, and also that they are in worse health status compared to any other population group. So it is important to pay attention to this group of women. They are shown to have less access to perinatal care. They use much less frequently perinatal care than other groups. Sometimes they even not using perinatal care, and they arrive at the hospital in a rather poor health condition. So all these complications, most of these complications can be avoided if they are provided with a good healthcare services. But why these differences? There are several barriers, and they we can group those barriers in 3 broad groups of factors. First, these are individual women characteristics. Every woman is unique and has own needs and prior experience. For example, negative prior experience with healthcare in home country could be linked to unwillingness to use healthcare in the host country. Also, there are many other factors like age, language skills, health literacy, cultural norms, religion, that could affect the understanding of when healthcare is needed and not during pregnancy. There are also, in case of migrants, we have also a huge group of determinants that are related to the migrant status. And also in case of undocumented migrants, it is also the main factor of fear of deportation. Anything that could expose undocumented migrant could be a reason for not using healthcare. Think about the need to register with GP. Think about the need to register with midwife for pregnant women. The need to pay, because there is a fee that has to be paid, not only because of inability to pay, but the fact that you are getting a bill can also create a fear of being exposed. You can think about many different factors that could create this fear of being exposed and being deported. And at the end, we also have the health systems features. So although European healthcare systems, they have really very good healthcare coverage, not undocumented migrants are not entitled to all healthcare services. There is quite a lot of restriction. Fortunately, maternal care is usually essential maternal care is usually provided free of charge across EU member states, but nevertheless, access to some other additional necessary healthcare services that are needed by pregnant women can be still restricted. So this kind of restriction because they are because of politics. It is European politicians. They want to make migration less attractive, and that's why in many countries restrictions has been implemented. Because I just sum up the plenty of evidence that there are about the difficulties of using maternal care being undocumented pregnant woman. But overall, this can lead us to certain strategies, to certain recommendations that could be put forward. And this is, there is a need to for targeted promotion campaigns for migrant women and also for undocumented migrant women. There is a need of personalized approach targeting different subgroups. There is also a need to separate politics from public health and health policy, which will allow to break the possible fear of deportation, and to make it more easy for undocumented pregnant women to access health care. So if I need to end this presentation with one important message which I would like to put forward, this is separate public health from politics, and among other things for the sake of undocumented pregnant women. Thank you.
Thanks, Milena. So if I understand, you're not saying separate, you're saying do not determine your policies on the basis of their status, provide access, if I understand what you say. But actually, can you do that without policy and politics? But that's not my question. My question would be the following: because in COVID-19, we saw different, for these population groups, we saw further access issues, including for primary care or prevention care, or even vaccination. I mean, this were groups that should have been prioritized, but actually they were almost the last to be vaccinated, even in Europe. The question that I have is, do we have at the moment any systematic measure of how these people are accessing, and or whether there are extra out-of-pocket payments, and or what actually costs the system in the long run from not providing them with access? Because of course, if there is emergency care, they do have access to that, but they don't have access to things that could have prevented them getting to the emergency care. So is there at the moment a systematic matrix, database project which is looking at that?
Yeah, I'm not aware of such project. It could be that I have missed, of course, but overall there is really a lack of data on undocumented migrants and also undocumented migrant women. If you look at the literature, or the academic literature where such evidence is reported, you will see that quite diverse type of studies, settings, which even does not allow to make any comprehensive across the countries, observed in different countries, but I think we miss data on to what extent which determinant is most severe and which should be prioritized. So this kind of information is missing.
And on a different note, when we were doing rapid capacity building in 2015 and in 2016 for refugees and migrants coming into Europe, what we saw, which was very interesting, was that the kind of information these groups wanted was not only information on their condition or their health, but information which had to do with legal rules, regulations, accessing judicial system and so on. So the question would be, do you think it's only barriers that are systemic, or do you think there's also fear for accessing even when the system is available, potential stigma for reporting? For example, we have cases where women could have gotten pregnant under difficult circumstances, not being willing participants, for example, or also deciding not to keep the baby. And also we've seen other traits, if you like, in the way people seek care. They're not necessarily the people determining how they're going to be seeking care. Somebody else, a family member, could be a man or not, is the person determining whether they're going to be seeking care and what kind of care. So do you think this a question of them being able to access? What is the biggest barrier, the system or the context in which they live, or the lack of knowledge of navigating the system? So we go into literacy.
Thank you. It is complex, so we cannot say that there is only one important barrier. For example, in the Netherlands, there is good knowledge about the system, how it is functioning. Usually this is not perceived as a problem, but still literacy and the need, the understanding when do you need healthcare could be very different across migrants and minorities, for example. So it's not just culture and religion, but it could be the fact being a migrant could make this very different, create a lot of differences. In UK, for example, there are certain projects where they distribute information among migrants how to access healthcare and what is the best way to navigate. Another issue with migrants is this idea that primary care is of less quality than hospital care. This could be also a reason for not accessing primary care on time. And this has to do with experience in own country. If you have been in a situation where primary care is provided with a low quality or is absent, then you are inclined to access hospital care. So it is a combination. Also, what is reported in the literature that sometimes also providers in the host countries, they do not know how to deal with undocumented migrants because this is not well specified in the guidelines. So it is a very, very complex issue and lacks clarity, and also is not enough into the attention of policymaking.
Thank you very much. There are other things that we would love to discuss: linguistic barriers, the burden of women in the healthcare workforce, the mental health we have. But I think we need 10 plenaries or for that, or 10 events. But thank you very much. Before we go back to Arpana, who was very, very kind and quite wonderful in her words to us, if possible, to get a very brief, starting from you, Milena, a very brief 10-20-second statement on what you think is a key focus for younger people and for students. I mean, we only have very few of us today because it's the really last event in a very long weekend, a very long day, but it's recorded. So it would be good to have it there, and it would be good to include it in the report. So starting from Milena, yeah, go for it.
Thank you. Thank you. I would like to point again my last message, which you might question, Elena, but this is separating public health from politics.
Yeah, no, I'm not questioning that. I'm questioning whether the effect to which it can be achieved, because the politics are shaping the policies. Policies are not happening to bottom up. There's also a comment from Yonette saying, excellent point, separate public health from politics. I mean, in the interest of public health, politics should be evidence-based, evidence-informed. So, but then I go to Yonette because maybe she wants to elaborate on that a little bit more.
I think that's a good point, Milena, and I think we can strive to it, because who would have thought People like myself would always say in public arenas and in policy arenas, not a policy person at all, but saying that we need to have more engagement of public health with economics. And no one listened. If you think of a government, the Minister of Finance sits next to the Prime Minister. The Minister of Health is way down the line on the table. Nobody really listens. COVID-19 has really radicalized that. You've got Kristalina Georgiana saying, the head of the IMF, who I dearly love because of her message. We have a woman leader at the helm of a multilateral economic organization saying, we cannot speak of health or public health without engaging, as economists, without engaging the health folks. We have to speak to them. So this is the time. And I truly believe if we as population health scientists continue to push, we can actually, Milena, one day we'll have a glass of champagne saying you were right. You proved that it could be done. So I think we should start a movement, separate politics from public health.
Okay, we're sticking with this. Maybe we can turn it into a movement. I mean, I think we are all of us, speaking also of myself, all leaders in our own rights. Thank you very much, Yonette. And also our thanks to the sibling to leave us. And Liz, I pass it on to you to do the rest and also, of course, to conclude. I think we have still Catherine with us. And perhaps she could have the next message and then we go to Arpana for the message and for the award. So do you want to take over?
Yeah, sure. Thanks, Elena. Catherine, could you give us a key message, please?
I assume you mean me, yeah? Is there another Catherine? Because earlier...
We had 4 Catherines today, but no, we do mean you, yes.
Okay. So, well, I could do 2 things. First of all, separate public health for politics. So I think this needs to be a little bit modified so that I agree. So, so politics are, for me, can be a drive for good, especially when it is evidence-based and it is based on good evidence. So if it's politics for the sake of politics, by every means, separate it. If it is politics to make public health better, to make the population healthier, no, then maybe we should invest in politics. So
thanks, Catherine.
That's my part of being controversial.
Politics is there to serve the people if done properly. So
Exactly.
we can fine tune, but the message, I think the message of Milena and Yonette is quite clear.
I understand the message and it weighs on me, but I think we do need a different kind of politics.
But let's see what we can make out of it.
So that's that. Now to my ending statement. My end statement is that we should invest in data research, data quality and interoperability for the sake of innovation and one digital health. Thanks.
Yeah, I add social innovation. So Liz?
Thank you. I'm not sure what panelists are still with us. Do we have?
We have Arpana. She's a panelist. And also I have to say, and I think I speak for both of us and everyone, our thanks to Greg, who's refusing to switch on camera and microphone. But really, we are thankful. I wrote it also in the panel. We are thankful to him for his tenacity and long evening hours in setting up not only this panel, but everything in the festival. So thank you very much, Greg. So I think we go to Arpana.
Thank you.
So just double checking, is this for my closing of the whole conference?
This is for your closing statement, and this
Closing statement.
Closing
Okay.
statement, and of course poverty. It's I found your last the previous plenary was very interesting. As I said, I felt very passionate towards the end. I wanted to step in and say, hold on, I have an opinion on this. So I mean, it's good to say that you want you're having something for alleviating poverty, because we end up going back to the root causes. And the root causes don't need necessarily a lot of new data to figure out, black is black and white is white, but okay. It's like the cigarette, the tobacco discussion. Do we need more data? No, we have enough data. It's a political decision. Thank you, Greg, for saying, you should have unmuted. So no, it's your closing statement, Arpana, and then it's the award, and that's it.
Oh, lovely. So closing statement 1, I'm going to put Liz on the spot. As I mentioned, this session has just been so inspiring. I think what we need to do is, Liz, when you're back off your holiday, well-earned holiday, is arrange a meeting with Elena and have a much bigger session on this topic, because there really wasn't enough time, I think. Just to say that Liz has kindly volunteered to, not just has she produced open access materials, but she's going to be developing that into a master's programme in women's health. Aren't you, Liz?
Yeah, very happy to hear that. And also Liz volunteered, and we've shared it, I think, when we disseminated. We kickstarted the SDG 5 working group. It's not a section, it's just a working group to see what the sections need. But it would be good, and we are already making notes. All of the speakers today should have half an hour at least to develop more material. So yes, thanks for mentioning this, and I hope Liz will manage this too.
And I think this is something for the European Journal of Public Health, isn't it, Ellen? Yeah.
I mean, that's the idea, that whether we try to make this today's event, I didn't want to say it because we wanted to make, we're going to be releasing probably Monday, the statement for UFA, sexual and reproductive rights. You don't want to announce something if you're not sure everybody will endorse it, because it's a very intense document discussing abortion rights and many other things. And it took 6 months to develop, which is much longer than most statements internally. So these are sensitive topics and with very mixed sensibilities. So yeah, we also see a lot of reaction from different quarters and of different types. So one step at a time.
Yeah, that sounds very good. I shall thank Liz and Elena, and I hope that we can build on this, and got it recorded, Liz, now. So I didn't know if you wanted to tell me off now.
No, not at all. And yeah, I think it's just amazing, and I'm really looking forward to us all working together and continuing to collaborate and share, and to make this something wonderful and keep building. So yeah, 100%. Thank you.
On to closing of the festival, and I'm hoping PowerPoint will work, because there's smoke coming out of my laptop now. So hopefully we can announce the winner. Amy Arnold, many congratulations. The intense voting thought your abstract and presentation on an evidence-based approach to improving the uptake of the COVID vaccine and reducing health inequalities was excellent, and we'd like to extend congratulations to you, and to mention our runners-up. Fantastic work, and we'd like to very much congratulate Charles Musigwa of the Catholic Relief Services, Robin McCarthy, that's from our Friend of the Festivals group, Penny Cook, hopefully she's listening in, and also our other runners-up are Ricola Cummings and Jeremiah Okpu. So well done to you and your co-authors. And our next set of winners, we have Looking for Flowering Trees to Walk Past, a qualitative analysis of older adults' experiences with parks and nature in the United States during COVID-19. So congratulations to Viveka Guzman and her colleagues, and a shout out to the runners up. Again, it was a close run thing. So congratulations to Sally Brown, Naomi Brookarsh, Anushka John and Louise O'Neill and their teams. And so I'd just like to make the slide go forwards. Just remind people that the website that is updated has our daily digest, which will include today at the bottom of the programme. Please follow us on Twitter at Festival of PH, as well as our Hub and MPH Twitter accounts are there. All of our online free open access courses and our CPD courses are available, and we will make sure all the links to our Facebook, Twitter, LinkedIn, website, YouTube, blog, and our CPD is available on here. As ever, I'm going to thank the team that have done an amazing job, and I think it is time to make Greg, if I can stop this. I think it is time, Greg. You're going to have to put your camera on.
I have had my camera on.
Well, you're going to have to be thanked now, Greg. So, reminiscing about when Greg first came to us all those years ago, and I'll share the photos, but he'll not be happy. So I think it's fair to say that Greg and Gary Clough, who I can't see at the moment, decided that the festival needed complete revamping, and it's only down, and I think, Elena, you used the word tenacity.
I did.
That is a good word for Greg and Gary, I think. So
it's his saving grace for some videos and music that are be trending on YouTube. So you have to find a saving grace. We all have something, you know. So for me, in his case, it's tenacity. Will you do this? Yeah. Will we do together this year? So he's, you know, he goes at it. So thank you for your tenacity, Greg, and for humor.
Welcome, Elena.
Whenever anyone says tenacity, I think of sputum, because I used to have to spin down sputum that was very tenacious in a past life. But yes, not equating Greg and Gary to sputum, but just to say all those years ago, well, 10 years ago, but 9 festivals ago, they decided to revamp it, make it as open as possible. And I think they've done a marvellous job year on year. And then this year, we've had the whole team that have taken part. And I think both Greg and Gary would agree it's been a team effort that's really focused on getting everything up and running, and all of these speakers with all the different components of all the special sessions. It's been a fantastic week. and we're going to have lots of really good spin-offs from this festival. I know it, I feel it, and I'd like to end by thanking the delegates and all the questions, all of our chairs, all of the people who've contributed to the planning, to the design, and also Ali George Davidson, my long-suffering PA. I don't know how she does it, but she always smiles. And without her, I don't know where I'd be on a day-by-day basis. But just to close by thanking you all, and well done, Greg and the team. Another marvellous festival. And so I'd like to officially close it. And I think it will be as Greg. Is that right?
He may well have started, you know, I'm just saying.
That doesn't sound like me, Elena.
Yeah. No comments. No comments.
So thank you so much, everyone.
There's a nice comment from John Owen to you.
Yes, please don't start talking about the US office. It's an interesting one. But thank you so much. And Greg, I'll let you do all the technical bits. So you're going to stop streaming.
I will.
Thank you. Thanks, Liz. Thanks, Greg.
Thank you.
Thanks, everyone.
Have a good weekend.